Arrived, it's definitely time to start. Okay, I'm just going to give a 30-minute talk. Much of it is a recent talk I gave to the CMT trainees, and it is, well, I think the most important challenge in any acute trust at the moment. It's all about patient safety. This is headline data, but we're going to talk about antibiotics and also about CQC and what they think are the most important elements of patient safety. I'm going to talk first. I guess everybody knows what standardized mortality rates are. The one that the NHS uses is the Summary Hospital Mortality Index, and it compares every trust in England. It has a predictive model about whether a patient has a chance of living or dying. I should put that the other way around, dying as opposed to living. And then they compare that predictive model to the actual outcomes of hospitals. It includes all patients, but also includes people who die within 30 days of leaving the hospital. Bizarrely, it does not adjust for deprivation, and there's no adjustment for palliative care coding. And the statisticians tie themselves in knots explaining why this is valid, but I'll show you some data which you'll think, well, that can't be right. And you construct a funnel plot, which is something like this. These are the ones that have the high mortality. This is band 2, as expected. And then these are the trusts that have a lower mortality. And of course, the implication when you look at it, and particularly if you're a patient or if you're in the media, is these are the bad hospitals and these are the good hospitals, and this bunch in the middle are just doing okay. And that's what people do. That's what people do. It's about 2 or 3 years ago, because of these outliers, they all had a visit from Bruce Keogh and his team. A lot of them were put into special measures because they were it's just like it's a bit of a smoke signal. That's what Bruce Keogh said. This is a smoke signal. If you go into trusts with a concept there's something wrong, you will find it. So these are the bad hospitals. That's bad, ironically, in inverted commas, by the way. These are the ones with a high mortality. So just have a look down that list. And these are the good hospitals. Does anybody notice anything about that? Yeah, absolutely. Most of the bad hospitals are in the north, and most of the good hospitals are in the south. And that's why you have to raise question marks over deprivation and other factors. There's also an issue, particularly in central London. Barts Health, biggest trust in the country, had the worst CQC report I've read in the last year or two, and yet they have one of the finest mortality records. There's a lot about the age of the patients as well in central London who visit hospitals. That's not to say that some of these hospitals aren't exceptionally good. And this is another one, Cambridge University Hospital, widely regarded as an excellent institution, very low mortality, CQC, just been in, absolutely slated it. The chief executive, who's a doctor, was summarily dismissed after that. So, these things have huge implications. So we're all bad in the north, and they're mostly good in the south, and that's what you tend to take away. So there's a regional variation, and the northwest has the second highest mean shimmy. So in other words, if the mean shimmy for the country is 100, it's always 100, it can't be anything else but 100, then in the northwest, the mean shimmy for all the hospitals is 1.04. And you can see in the northeast it's even higher, and you see London? So it's way down. So there is a regional variation here. And where is the Royal? That's not a very good arrow because that's a blank point there, but that's us there. And on the shimmy test, we've never been good, we've never been bad. We've been between about 103, we went up to 109 last year sometime. Now, you ask, well, where are the other trusts on this? And Aintree, I have to say, Aintree were an outlier for years, and they've done really good work. I don't know what the main factors are, but they've reduced their shimmy to slightly less than ours. So, yeah, well done them. At the moment, Warrington are a persistent outlier. Southport have been an outlier as well. So we're sort of somewhere in the middle. Somewhere in the middle. I just want to show you this also. I think a lot of you worked on the front line will say last year was really difficult, really difficult. A lot of sick people. Well, you were right. There were a lot of sick people because there was really quite a marked seasonal spike in mortality in 2014-15. Much higher than the one before, in line with 12-13, and much higher than 11-12. But the only explanation I've heard for this is that the flu vaccine did not work. It gave less than 10% protection, and the excess mortality was due to pneumonia, particularly in elderly patients. So huge variation. I think it's important to recognise that, especially when you look at the common causes of death. So we have more deaths than expected. Don't forget, this is just a statistical model, okay? But the major cause of death by far in our patients is pneumonia. After that, AKI, and of course AKI is a multiplicity of things which just is tagged under acute kidney injury because the renal function is worsened, but it could be dehydration, it could be GI bleed. There are loads of possibilities why a patient is tagged as AKI. Cerebrovascular disease, COPD, aspiration pneumonia, fracture neck edema. So those are our observed deaths, those are our expected deaths. And you know, we do look into this in more depth, and we've had good quality audits in AKI. I must ask Dr. Anajit why our advancing quality performance is so bad in that. You can possibly tell us about that later, because I was just looking at the data this morning. And so, but again, there are anomalies. Pneumonia, this is community-acquired pneumonia, and our compliance to pathways on that is pretty good. You know, most of the patients will get antibiotics and assessed when they come in through the door, and yet there are more deaths than expected. Whereas aspiration pneumonia, when our respiratory physicians did an audit on that, they thought we treated that very badly. So there's something odd, and that oddness is probably related to coding, because what you write in the notes is what the patient is recorded as dying of, okay? But it's not what you write in the notes when the patient is in the dying phase. It's what you write in the notes when the patient comes into hospital. And that's a very important thing to understand. This record is what the clinicians say is wrong with the patient when they come into hospital. I think we'll skip over that. Just shows pneumonia is the biggest cause of death there. Just very briefly, we talked about evidence-based practice in the past, and we're putting a lot of effort into delivering that. And the pathways are recorded in what's called the Advancing Quality Initiative. And we're doing this because there is evidence that this reduces mortality. So just as an example, if you give antibiotics within 4 hours of presentation to a lobar pneumonia, there is a huge amount of evidence that will improve survival. Similarly, if you give patients antibiotics within 1 hour of diagnosing sepsis, there's huge evidence base that this will reduce mortality. And in each of these major conditions, AKI, cerebrovascular disease, COPD, and fracture neck edema, we have evidence-based pathways, and the reason that we want to stick to them and demonstrate that we're doing them is that the evidence is it improves mortality. Going to move on to antibiotics stewardship now. I am what they call the DIPSY. It sounds as though I've got some sort of mental illness or I drink too much, but in fact it stands for the Director of Infection Prevention and Control. And I'm qualified for this because I know nothing extra about microbiology or infection than anybody else in this room. And it's not about that. It's about being accountable. So, When our regulators, when Monitor or the CQC or anybody else comes in and asks us about infection control, I am the person who has to respond to them. I'm the person that's held accountable for the performance of the trust in terms of infection. So not surprisingly, I've had a lot of focus on this because it is one of the major challenges for every single hospital and healthcare system, well, not only in the country, but in the world. So the first thing to say is I am very pleased that the antibiotic stewardship on audit has improved right across the trust. So we're very good at choosing an indication for the right antibiotic. We're pretty good about writing the duration of antibiotic treatment, and we're very good about antibiotic antimicrobial choice. The target is 100%. Some hospitals actually are delivering 100%, but they tend to be the hospitals where they have a prescribing system which doesn't let you do it any other way. So when you write up an antibiotic, you can't not put what the duration is. It won't let you. We don't have that in the hospital. So a lot depends on the actual, the sort of assiduousness of the prescriber. So those who are prescribing, thank you very much. We're improving. We need to carry that on. And I'll tell you why coming up. So these are the major infections that we get recorded in the trust, MRSA, not because it's common, because it isn't, because we've only had one this year. It's because it's an indication of how good we are at putting lines in, how good we are at caring for lines, how good we are at screening people who come in with MRSA. That's what it's about. It's not about this one infection here. So that's improved. It's fantastic. Coincidentally, as we've improved our MRSA rates by better care of lines, and I'm sure that most of you here are ANTT trained, and I'm going to say a little bit more about that in a tick, our MSSA rates have started to decline as well. So that's really good news for us. Except I pointed to the wrong graph. Here it is here, MSSA. Also, C. difficile rates, we've had 22 this year. About 5-6 years ago, by this stage, we would have had 150 cases of C. diff. The change is dramatic. And you know, if you've seen elderly patients with C. difficile, we know what a degrading is the wrong word. We know what a terrible thing it is for them to go through. And we have to do our utmost to avoid patients getting infections due to this. Why did they get it? Improper use of antibiotics, but also cross-infection. Okay? So I can tell you that amongst these cases of C. diff, most of them I would say were not avoidable. When we go through the root cause analysis, they're not. The antibiotics have been used appropriately. They're just ill, often elderly patients with complex diseases. And I come and I listen to the clinicians and I often say, well, what in the world could we have done about that? And we take those to appeal. We say that, you know, the hospital was not at fault about that. 3 or 4 times this year, we have shot ourselves in the foot by taking patients with diarrhea from the ground floor and putting them into open bays and having cross-infection. And this has just been done sometimes because they haven't been able to get a sample on the ED, sometimes because they didn't have type 6 or 7 stools in the ED, and sometimes because doctors, and this is good doctors, made clinical judgments that this was not an infection. And were wrong. But the judgments were there. They did what they thought was best for the patient. So there's no sort of, you know, there's no sort of grief coming from me about that. They did what they thought was the right thing. But there's clearly a risk from anybody with diarrhea. And that's one of the reasons I'm trying to put more pods in the hospital. Has anybody heard of pods? Anyone? No? Okay, on the ground floor, in AMU, you will find in one of the rooms, can't remember which one it is, I think it's room E, there is a Perspex container almost around one of the beds. It's called a pod. So I'm having an initial tranche of 6 put in across the trust, and we hope to get up to between 20 and 30. And we'll put them in the bays. We'll reduce the number of beds from 4 down to 2, and we'll put 2 pods. And these are for patients with possibilities of infection, and so that we can admit them there isolate them and prevent cross-infection with other patients. So overall, we're doing pretty well. It's a battle out there. I'm pleased with the progress we've made, but you take your eye off it, and I can tell you the infections, they just crop up immediately. ANTT is really interesting because I think it's made a big impact, and I'd just like to, there's consultants there, I'd just like you to reflect on the junior doctor strikes that may be coming up in December, in 3 days in December. And if you could have a think about with your directorates, are we ANTT trained? Because you'll be putting the lines in, I think, in some of these patients. And the other thing I'd like you to think about is, can you prescribe on the EPMA? Because I can't. So, I mean, it's going to be a little bit of a difficult situation if the junior doctors are off and the consultants are on the ward and we can't prescribe. So that's something that we've got to address over the next few weeks. Okay, CPE, carbapenemase producing Enterobacter, multi-resistant organism, has not caused many infections in this trust, but it is carried by an increasing number of patients. We had a mini outbreak in August, almost certainly due to cross-infection, and there are a couple of areas that were particularly affected by it, notably orthopedics. I think a lot of that had to do with tertiary referrals coming in. But there's no treatment for this. I say no treatment. There are some antibiotics that you can use if you get systemic infection. A lot of them are very old-fashioned things like colistin, which are really quite toxic drugs. So the thing is that the less carriage, then the less potential for multi-resistant infection. And of course, just to say that we in this trust have our own brand of CPE, our own strain. It's specific for this trust, and it's a Klebsiella. And it's probably from areas such as ITU, the pancreas unit or the hematology unit, really immunosuppressed or very ill patients that have had a lot of antibiotics. But there has been a spread in different areas of the trust. And there's, as I said, little you can do apart from absolute meticulous and basic infection prevention and control measures. So that's the second part of this short talk. The third part is CQC. CQC will be coming to visit us in, I think it's the third week in March. I've already been through one of their visits, and I've been on the other side, actually inspecting a couple of trusts as well. It's a huge undertaking. They'll probably bring something like 40 to 50 inspectors, and they'll stay in the trust for 4 days. And they will be absolutely everywhere over the organisation. And they do identify significant risks and sometimes things that we've missed. So overall, it's a beneficial exercise, and it allows us to focus on our weak points. They've just put out their annual report called The Safety of Hospitals, and they actually said that patient safety, out of all the domains that they inspect against, and there are 5, safety, caring, responsiveness, effectiveness, and well-led. Those are the 5 domains. Safety is the biggest challenge. So out of 100 trusts inspected, only 26 were rated good for safety, and no trust was rated outstanding. 61 were requires improvement, 13 as is inadequate. And of course, CQC inspect many areas. They do GP practices, they do care homes, they do mental health trusts. But it is acute hospitals where patient safety is the biggest challenge. These are the things they said they were concerned by. And I think in every area we'll think, yeah, we could have done better there. Safety checks and audits, essential training and mandatory training. I have to say, how many times have we missed elements of mandatory training? I'm not innocent on that. Inadequate management of medicines, ineffective record keeping, not sticking to the news escalation, disregard for infection control practices, and poor streaming of patients. Those were their major concerns. In good hospitals, they flagged up participation in audit and sharing learning. and also reporting incidents. And I think that as a trust, we'd really like to encourage this. If you see an incident that concerns you and you think it's related to patient safety, report it. Even if it's a near miss. It doesn't have to, patients do not have to suffer harm. Just report it. Every single incident is reviewed every week by the patient safety team. And that includes some very senior members of our staff. So it will be seen and it will be acted on. So CQC are very keen to ensure that there is good reporting and learning in hospitals. It's also important for the board, they call it board-to-ward reporting. So it is very important for the senior members of staff, because there are loads of levels between the ward and the board, that senior levels of staff know what's happening. And that's why it's important that junior doctors and junior nurses report incidents, and that is escalated through the system. And one thing that was brought to my attention yesterday was very poor feedback, particularly to junior medical staff. And that's something that we will be addressing over the next few months. Because the ward staff should have a system by which they get feedback, whereas we don't have a system to feedback to junior doctors. So we'll try and improve on that. This is the final slide. These are my patient safety targets for the Trust for 2015-17. And I'm not doing very well so far. So the first one was reduced mortality and save 200 lives. Well, quite frankly, because of that winter spike I showed you, we had 100 additional deaths in the Trust in 2014-15 compared to 2013-14. So I haven't saved many lives on this. 95% compliance with mortality peer review, and we haven't delivered that. It's about 80%. Some of them are very good, some of them are less good on that. Reduced cardiac arrests, we haven't delivered that either as yet. Obviously, that is a reflection of ill patients, and in the winter, the cardiac arrests went up, not surprisingly. Broad green transfers have improved quite significantly, the safety of those transfers, and there has been widespread implementation of the new system throughout the hospital. Sepsis is interesting. Reduced mortality for severe sepsis and sepsis shock. Dr. Nsutebu tells me we have done this. But if you look at our reporting data, we've recorded more deaths in sepsis this year compared to last year, and that's because we've actually reported more cases of sepsis. So patients that previously were recorded as dying of pneumonia or urinary tract infection, they're now being recorded as dying to sepsis, which is right and proper. VTE, we are complying 95% to the first assessment, but we're not compliant to NICE guidance. Falls have improved in terms of serious harm. Tissue viability has improved. No incidents relate. I'm actually not sure what that is. Medicines management is a big area for CQC. The biggest causes of concern in our trust are missing critical medicines. We had a patient who died of epilepsy who had not received the anti-epileptics. Went to the coroner. There was apparently a syndrome called sudden death in epilepsy. But you have to be concerned that it was related to missing some drugs. We've had patients who've not had their heparin, and we've had patients who've had their heparin twice. We've had patients who've not had their gentamicin, and we've had patients who've had it twice. And the big risk is the handover from AMU and ED to the wards. So that is a big area of concern. And dementia and catheter-associated urinary tract infections, we are making progress with the urinary tract infections. We're nowhere near the dementia targets. So they're all very challenging, they're all very appropriate targets, they're all things that we should be delivering as a matter of the normal course of our work. I think that, I know for many people, you get pathways and you get forms and you go, oh, can't I just get on and treat the patient? So we're going to really try and make the forms easy to do electronically as you go on. But what I want everybody to realise is that these pathways, if you put them into place, they do work. The evidence base is now enormous. They do work. So I'd encourage everybody, particularly when they're seeing pneumonias and sepsis and all those ones that are included in advancing quality, stick to the pathway. Your patients will do better. Okay, I'm going to leave it there. I can take questions for a couple of minutes before we go on to the second part of the morning. Annie, do you want to say anything about AQ compliance? They said it was 2%. I couldn't believe that.
I can't believe that as well.
Thank you.
I'll have to catch up with Becky and the AKI team. That's very surprising to me because I think the AKI nurses were filling the forms at the end of the week, every week.
The only reason I know is that the chief executive asked me for an update yesterday, and I was looking through all the data, and I thought, I can't believe that's true.
I'll have to catch up with
Thank you.
Just a comment on the peer mortality review process. I lead our directorates on, and I know there have been recent changes in the stewardship on reporting these. Just a couple of comments to make there. I mean, it's oftentimes a very difficult task, just even trying to retrieve the notes. I know some directorates do well. I don't know if they hold on to the notes and finish it before they are sent off, but it's a huge task trying to get notes to complete some of these. I know the benefits. We go through it through our mortality meetings, and you can pick lessons from there. But the other thing that has also changed is previously we used to have, at the beginning of every month, you have a report from the previous month. With a change in stewardship, that's also not coming through.
Antibiotic stewardship?
No, mortality.
Mortality peer review?
Yeah.
I think they still do it monthly.
I haven't had one for the last couple of months, unless I've requested for it.
Okay.
And then the last one is to do with inter-directorate meetings, which used to be possible on the previous form, but it's been removed. And I've been doing this for a year now, and I'm not aware one of those which were requested when I took over about a year ago has happened.
Okay.
And I've had to be sending emails, so those are things which may need to be looked at.
Thanks for that. Yeah. I think, did you want to say something, Julian, about that?
Yeah, right. I think you're absolutely right. I think until you do comprehensive mortality review for your department, you're not really going to learn the lessons which are necessary, partly because the notes that are missing are the ones which have got all the problems in, because they're off with the coroner, with the medical legal department, with the complaints department, they're in somebody's office. So it's really important that we do that. We are going to start scanning the notes and accessing them electronically on the 23rd of November. That's when the first set of notes go off, and you will be able to view all of the notes electronically at that point. We're actually going to start with the fact files and the deceased patients as well. So hopefully that we will be able to address that problem. But I think you're absolutely right. It's a Herculean task to achieve 100%, but I think valuable.
Yep, fair enough. You're right. The average mortality peer review in the country is between 75 and 80% for exactly the reasons that Julian's pointed out. And the notes you really want, somebody else has got them. Yeah. Janice?
Can I ask about coding? Because consultants actually view coding as very important to support accurate diagnosis. You mentioned that obviously what's being presented by higher powers and statistical analysis is based on something that's not necessarily accurate. And as I understand, it also underlies the financial reimbursement for the trust and therefore developing services, etc. I'm not sure that the trust, they talk about the importance of coding, but in practice, the coding experience for consultants and departments is getting worse. And I'm not clear why we don't have coders embedded within departments so they are familiar with the coding. Each department has to do it slightly differently, so that we get the most accurate data, so it can be properly analysed and benchmarked. And secondly, the trust gets the money that's deserved.
No, I think that's right. Coding is spectacularly important. We get paid. We don't get paid on the admission diagnosis. We get paid on the final diagnosis. So it doesn't affect the finance in the same way. We have done quite a bit of work on coding. We sent out, should have little cards about, what to write in, like don't put query, don't put impression, don't put possible, because the coders just completely ignore that. They're not allowed to use those as diagnostic codes. In terms of admissions, we, the Trust, have one of the highest uses of R codes in the country. And R codes are symptom codes. So we have lots of patients who are coded on the admission code as short of breath, off feet, what's another one? Superficial bruises, that sort of thing. And we used to have a lot of deaths in these R codes. So every time there's an R code now with a death in it, I review it to look at the coding. I'll just give you an example because I saw one yesterday. Patient came in, diagnosis of cause of death, short of breath. And that is because the doctors who saw the patient had written, the first one had written query underlying malignancy, and the second one had written impression bronchial carcinoma. And the patient did have a bronchial carcinoma, but under coding rules that would have gone off as died of shortness of breath. I did change that one. I am allowed under the rules to change it, but I've got to write in the notes that this has been changed. The reason that coders are not embedded with the department is that they have a training program, and that it's like junior doctors, like junior coders, they go up through the system, and they like to get training in lots of different areas. However, orthopedics now have a dedicated coder, and that was indeed about making sure we maximize our financial income from that. And so I would like, personally, I'd like to see a coder attached to each directorate. I think it would be very beneficial. I've not been successful in persuading the coders to do that at present time. Julian.
Sorry, I think it's a really important point that you raise. And I think there are two things which we've done which help enormously. I think there's now a requirement when the death certificate's being done that the diagnosis entered is discussed with a registrar or above. And actually that's improved the quality of the death. I think the least we can do for the relatives is get the diagnosis right on the death certificate. It stopped us bothering the coroner with things which are not necessary, which disturb the family too. So that's the first thing which I think has helped with data quality. And in fact, my SHO rang me yesterday from the bereavement office to say, can I just clarify this before I fill it out? And we were able to refine the death certificate. But the second thing is, the coders are allowed and have been allowed for the last couple of years to use the electronic discharge summary as a source of the diagnosis. And actually a lot of departments have actually worked with their coders and have actually got their diagnosis list refined, and it's coded as well. So actually it helps them in terms of their workload. But if you supervise, I think there are only 3 bits of the electronic discharge summary as a senior doctor you need to supervise. One is the diagnosis going in, so what's the diagnosis they leave with, making sure the meds are right, and what the follow-up is. And I think if those 3 things are assured on the ward round, actually the rest of it probably sorts itself out. But it's those 3 things for me, and I think if you can get the diagnosis from the drop-down menus refined, you'll improve the quality of your data.
Thanks, Julian. I think we better end it there because we've got the second presentation. 20 minutes, you said, Bobby. Is that right? Excellent.
Good morning and hello everyone. So the IV fluid team, which comprises of FY doctors and the members of the nutrition support team, have been trying to create awareness on IV fluid management among the hospital staff for the last few months. Maybe you have noticed that. And this is, we are doing this through teaching, sending and introducing the IV fluid flow charts on the wards. And also we set up a stand, IV fluid stand in the education center last week. So today we shall present the results of the survey. Now this survey we conducted among the hospital staff to enhance the understanding and knowledge on IV fluid administration in our patients. And so we will present the results of this survey today, and we shall also find out what are further ways of improving the IV fluid management in our hospital. So I'm going to invite the team of these young FY doctors here who are going to present the results of this survey.
Morning, everyone. Is that on? Yeah. My name is Jenica Patel. I'm one of the F2s here at the Trust. Myself, Danny and Jen are just going to talk about the work we've been doing that Dr. Mishra has just outlined. So I'll briefly talk about the aims of the talk that we're going to do today. I'm going to talk a little bit about the background of why we've thought raising awareness of IV fluid in the Trust is important. Discuss a little bit about the new IV fluid flow chart and policy that's been rolled out across the Trust. Talk a little bit about the IV Fluid Awareness Week that was carried out last week in the hospital and what we did. What Dr. Mishra has just discussed, the survey, we did a sort of pre-awareness survey to staff across the Trust. So we're going to discuss that survey and the results. And then towards the end, just going to discuss some of the key messages we'd like you all to take away from today. And we just want to highlight some of our future plans in continuing the work that we've already been doing. So a little bit about the background. The National Inquiry into Perioperative Deaths in 1999 highlighted a number of important and key issues. The report's quite from a long time ago, but these issues are still quite relevant today. It highlighted, as you can see, a significant number of hospitalised patients were dying as a result of too little or too much fluid. It found that there was a lack of knowledge among junior doctors, which is quite important because often the task of IV fluid monitoring, assessment and prescribing is handed down to us junior doctors. It found there was a regular review of fluid balance charts, and there was often a lack of appreciation of the need for fluid replacement in hospital patients. The relevance of this document was also highlighted in NICE guidance in 2013 on IV fluid therapy in hospitalised patients. And it highlighted that as many as 1 in 5 inpatients could suffer complications and morbidity as a result of improper IV fluid management. It also highlighted that before this guidance, there wasn't really a consensus of what IV fluids we should be using when and where. Which led to a wide variation in clinical practice and therefore patient outcomes. Little picture there is the BBC News actually picked up on some of the quite shocking statements that NICE guidance had picked up on the dangers of improper IV fluid management. So this is our IV fluid policy that we rolled out in the Trust around September time, and we tried to place it on all the wards. It's an A3 sheet, as you can see here, by Danny, and it should be either found on the nurses' station or on the documents trolley of most wards. It is based on the 2013 NICE guidance, and as well as on the wards, you can find it on the emergency handbook, which is via an app, which you can get on your phones or through the homepage. The lab handbook, again, which is on the homepage or through ICE. The intranet document system, and also we tried to send some trust emails a few months ago as well, so some of you may have that on your emails. To try and improve the awareness of this new IV fluid policy and also to improve our prescribing, we carried out an IV Fluid Awareness Week between the 2nd and 6th of November, and that was in association with the National Pathology Week. As Dr. Mishra highlighted earlier, we carried out a few events throughout the Trust to try and improve knowledge to the professionals. We did a number of teaching events, including delivering teaching at the F1 teaching, the F2 teaching, and to the A&E department as well. We had an education stand throughout the week between the hours of 12 and 2 in the Education Centre. We also provided some ward-based teachings, going around to the wards and trying to give short teaching to staff. And we also had a screensaver as well, trying to highlight what we were doing in the Trust. So the few little pictures there of what we did, we advertised the event as well on the National Pathology website, and there's a few photos there from the teaching and the education stand.
Okay, so Over several weeks, the team of us developed a questionnaire, and we used this for a pre-awareness. So over the past few weeks, we developed a pre-awareness questionnaire. Basically, had 12 questions on there and covered different aspects of IV fluids. So this was more of a pre-awareness questionnaire before the IV Fluid Awareness Week, and this was to gauge staff's awareness and what their understanding was, also to see what their base knowledge was and what gaps in knowledge were, which areas people didn't know about, which areas people got wrong. So we did this across the whole hospital. We unfortunately didn't get a chance to go to Broad Green, but we thought that this could be repeated after the educational events that we've done. So as you can see there, there's different types of questions as well. Some of them are free text and some of them will circle the correct answer. So we had 146 questionnaires filled in total, and you can see on the left different grades and different types of staff that we spoke to. So we had a nice range of doctors of different grades. We had nurses, we had some allied health professionals, pharmacists. We had some students as well. For the purpose of the results, we didn't include the students, so we only looked at 124, but we thought it was a good opportunity to educate students at the time and to sort of go through the questionnaire and explain things to them and identify resources for them to look at, explain the nice guidelines, and gave most of them a copy of our flowchart to take home and have a look at. A lot of them felt they had gaps in their knowledge. So of the 124 members of staff, on the right you can see where we spoke to everybody. So we had a nice mix of wards, surgery, medicine, the ground floor. We tried to have a mixture on the A and B, X and Y side. So we tried to go to pretty much every ward and speak to all different sorts of staff there. So our first question was whether or not people were aware that the Trust has an IV fluid guideline. Although 80% said yes, a quarter of all staff didn't know there was a guideline for IV fluid prescribing, which we hope now they will be aware of. We thought that was slightly concerning. Next question was, where did they see the guideline? Of the 80%, we asked, where have you seen the guideline? And we gave the options at the bottom, so the lab handbook, emergency handbook, just email, ward flowchart, teaching or intranet, and they circled the ones they'd seen. So obviously 35% of people had seen the ward flowchart. So obviously this is shown to be quite good. Other people have seen it from other sources as well. We then asked a question on the clinical indicators of hypovolemia. We had a free text question asking, can you list as many clinical indicators of hypovolemia as you can? 15% of people couldn't list a single one. And you can see between 20, 22, 27, 19%, most people listed between 2 and 5. One person listed up to 12. But there's quite a lot of signs on the news chart. For example, there's the tachycardia, there's the low blood pressure, the low urine output. There's quite a few that we would expect staff to know. So we obviously inform staff about those. And then on the flip side, we asked staff on the clinical signs of fluid overload, and this was a multiple choice question where we put all the answers on the bottom line, so peripheral edema, low urine output, shortness of breath, raised JVP, high urea and ascites, and they had to circle the ones that they thought were clinical signs of fluid overload. So obviously urine output and high urea are the wrong way around. However, 20% of people thought low urine output was a sign of fluid overload, and 12% thought high urea meant fluid overload as well. Most people saw peripheral edema as a more obvious sign of fluid overload. Not all of them sort of recognised ascites as a sign either.
Okay, so our next question was regarding what's kind of the daily maintenance of sodium that you should have in your IV fluids. So as you can see, 39% got the correct answer of it's 70 millimoles for a 70 kilogram person, so that's 1 millimole per kilogram in 24 hours. However, it was kind of quite worrying that a lot of people thought that your daily requirements of sodium was a lot higher than this, which is kind of reflected in our practice of prescribing. A lot of people get too much sodium in their IV fluids. So our next question was whether people could identify the correct IV fluids. So in terms of how much sodium, chloride and potassium are in those fluids. So can anyone tell me, giving the table at the top, which one would that correspond to dextrose? So how much sodium things are in dextrose? Yeah, so 0, there's no sodium chloride or potassium in dextrose. And then the 4% dextrose and 0.18% saline. Does anyone know what that contains? Yeah, 30 and 30 of sodium chloride. 0.9% saline. Does anyone know? Yeah, 154 sodium chloride. And then Hartmann's. Yeah, the one with lactate in. So, yeah, so you've got to be a bit more careful with prescribing Hartmann's. And then we do 5% albumin. That's obviously the one that's left over, so 150 of sodium and chloride. So as you can see, we've put there how many people got them all correct. So only a quarter of the people we surveyed got them all correct, which is a bit worrying because kind of the point is you shouldn't be prescribing something if you don't know what it contains. And 13% of the people that we surveyed didn't get any of them correct. So that's a bit concerning. So our next question was a clinical scenario. So you see a 6-year-old gentleman with gastroenteritis. He's got diarrhea and vomiting. He's got tachycardia, hypertension. What would be your immediate IV fluid therapy? So this was trying to gauge people's awareness of what should be your initial resuscitation fluids and how long should you give it over. So the majority of people got it correct, 50 millimoles of Hartmann's stat. However, 20% thought that you'd give saline over an hour, which saline is not necessarily the incorrect fluid, but in terms of a fluid challenge, you'd want to give it quicker than that in order to see if there'd be a clinical response to that. And 4% did say dextrose, which obviously is not really appropriate for resuscitation fluids. So we next presented them with this table to see whether they could identify what types of fluids should be used for what reasons. So we've got here that dextrose should be used for maintenance, and it kind of can be used as a specialty fluid as well for like GKIs and things, but it shouldn't really be used as replacement or resuscitation. The dextrose saline should only really be used for maintenance. The saline can be used for maintenance, but we would say that you should be using less than a litre of saline as part of your maintenance fluids. And it's more for resuscitation and replacement. Your Hartmann's is the same. You shouldn't really be using more than a litre of that. Well, you should be using less than a litre, really, for Hartmann's, for your maintenance fluids. Albumin is purely a specialty fluid to use in kind of special circumstances, and jelly fusion should only be used in resuscitation.
So that's the end of our displaying our results from the initial survey. What we hope to do is at a later date, once we've carried out further teaching, is repeat the survey and gauge on how effective we have been in teaching professionals throughout the trust. We've got a few key messages we'd like you all to take away from today. IV fluids should be regarded in the same level as other medications. They are, it's a prescription. We should really know what we are prescribing, what we're prescribing it for, and also how we should be monitoring what we're prescribing and the effects it has on the patient. Briefly, we'll talk about there's 5 main principles of IV fluid prescribing we'd like you to take away, called the 5 R's. Reassessment or assessment. So we should be, NICE guidance say this should be done every morning on ward round for the patients. They should be assessing their fluid status and whether they have any need for IV fluids. This should take into account whether they need routine maintenance fluids. So if a patient's nil by mouth, they're pre-op for whatever reason, do they have any maintenance fluid requirements? Do they need any resuscitation fluids for hypovolemia if they're, quite unwell? Do they have any abnormal losses, sort of GI losses, vomiting, stoma losses, and do they need replacement through the IV route for those? And also we need to consider the redistribution of these IV fluids, so what IV fluids we're using, where they're going to go once we administer them. We understand that IV fluid therapy and prescribing isn't always easy. It can be quite complex, and often our patients have got a lot of complex needs and lots of different clinical, often conflicting different things going on with them. So it can be quite difficult. So if you do need any help, please don't hesitate to contact the biochemistry department or the nutrition team, whether it's about individual patients or if you feel in your department you'd like further teaching on IV fluids as a group, so we can provide some more teaching for you as well. We'd just like to highlight that no IV fluid should be regarded as safe. There are always potential side effects, complications and harms that could arise from the inappropriate administration of IV fluids. With the with also rolling out the new flow chart that's on the wards, we have started using a new fluid, the dextrosaline that we've talked about briefly. That's got a lot less sodium, so for patients, so he's actually the preferred maintenance fluid now when people nil by mouth or need IV fluids for that reason. And it should be on your wards. Again, if you have any questions or concerns about that, if you can't find it on your wards, please contact our team and we can help with that. Just got a few plans for the future to try and continue the work that we've been doing. We want to continue to improve knowledge. As you saw from the questionnaire results, there are some gaps that we have identified in people's knowledge that we hope the awareness that we've done so far has helped in addressing those problems, but I think there's still work to be done. We hope to reduce prescribing errors and also complications that arise from that to improve patients' clinical courses. We're aiming to provide further teaching events throughout the year, and also we hope to incorporate this into local staff induction as well, giving brief teaching, so hopefully that will improve knowledge as well. Thank you very much for listening. Does anyone have any questions?
I don't know whether we have time to take any questions, but we are ready to take questions and see.
The question was about the availability of the dextrosaline. I'm happy you said it's available on the wards because it's not something that I've come across in my year of being in this hospital.
Really?
Can I answer that one? I'm Helen, I'm one of the pharmacists with the nutrition team. I also work on surgical wards and critical care. When we identified NICE guidance was asking for dextrosaline, I got dextrosaline put on the stock list of every single ward in this trust. So if it isn't there, we've had a lot of, it should be there. We did identify that some wards were sending it back saying they didn't use it, which was how we identified that there was a problem with the awareness. I think a lot of it is down to nursing staff that being very set in their ways, feeling they've got a lack of storage on the wards, and that if it's not prescribed, why do they need it? So we're doing education with the nurses. It's definitely on every ward. There's a plain bag, there's a 20 millimole bag, a litre, and a 40 millimole potassium bag. And if your ward areas haven't got them, they should speak to their ward technician or pharmacy distribution, or just fill out in the pink books an order, because there's no reason why they shouldn't be on all the wards. They've been there for about a year. So in actual fact, it is because we've met so much resistance that people just are blinkered to it. They just see the fluids they want to see in their stock rooms.
Dennis? Andy? The hand raised up.
IV fluids aren't obviously on the electronic prescribing, which is a problem. And you can come across somebody who over a few days the sodium's gone up very high while nobody's looking, and yet there's sort of a fluid chart for them. So is there a plan for IV fluids to be electronically prescribed so that it's easier to audit and monitor?
I think I'll ask Helen to reply this because she's a person.
As far as I'm aware, our current EPMA doesn't allow for it. Obviously, there will be new versions of it coming out. We would find it difficult. It's like there's other thing, palliative care drugs, that we don't put on EPMA, the TPN. Once, obviously, the hardware allows us to do it, ideally that would be the best scenario. What people should be doing, though, is actually prescribing IV fluid C-paper chart so that the nursing staff are looking at the fluid chart. There was also a move about 2 or 3 months ago to ask all wards to put their IV fluid prescriptions in a folder which should go round on the ward round each morning and should go on the medicines round so that things weren't being missed. But as a part of the nutrition team, I go on a lot of wards, and there's very few wards that are compliant to this. So it might be something we need to have another push with.
And the final question,
I'm going to say we're loading more and more into the induction training. Any plans to try and reach into the university to improve the standard of teaching before they come through?
I think that will be really helpful, and recently I've created some slides for the education which I have been trying to distribute it to everybody who is interested in teaching the IV fluid. And I've sent a couple of slides to one of the pharmacists who has been involved in undergraduate teaching. So I think that will be really wonderful, and we will work on it further. Maybe I will find out how we can promote further education for the undergraduate students.
You're quite right, absolutely. It's got to start with undergraduates. Now, I've got these certificates to hand out for their participation in the IV Fluid Awareness Week. So if you can just give them all a round of applause. Alison Young, who's got more certificates than I can shake a stick at. Srinivas, I can't pronounce that.
No, she's not here.
Not here. Jenica Patel, well done you. Round of applause. Batichi Nagaswaran, not here. Daniela Jones. Danielle.
Danielle.
Come on down, Danielle. Come on down.
Danielle was responsible for our IV flow chart.
Well done, Danielle.
Which has had the biggest response to all our teaching. So she worked hard on it.
Yeah. Round of applause for Danielle. Daniel Gibney. Well done, Daniel. Jennifer Chalmers. Jennifer. And Helen Campbell is Helen Campbell. Thank you very much. Grand round is over.
We have got a few more of the posters if any areas want them. And I've also got some copies of the handout if anybody wants.